Hi, today we will be talking about perinatal bereavement and palliative care in the context of US healthcare. And if you want to read the article that inspired this presentation, you can read the DOI right here on the screen and use it to search for this article. So first of all, perinatal palliative care is a family-centered approach that augments maternity care with support for parents who are continuing a pregnancy affected by a life-limiting fetal condition. Palliative care means end-of-life care, so the parents are aware the child will die either still in the womb or shortly postpartum or during birth. Losing a pregnancy is, of course, a physiological event. It happens in your body, but it also has implications in your psychological and emotional state. And of course, the way you are already dictates how you'll handle the situation. But no matter what, this will have repercussions and consequences that will touch on your emotions, and that will, have ramifications on your thoughts. And a lot of people need time to recover after they go through a pregnancy loss. Of course, it is also a social cultural event, meaning that it is contextualized within a culture. And of course, it has social meanings to family, to community. It depends on your specific circumstances, but different cultures view pregnancy very differently. And of course, the meaning of a pregnancy and the loss of that pregnancy can also change depending on your social context. When we lose a pregnancy, we don't just lose a real baby. We also lose an imagined baby that we had preconceived in our minds and that we held very dearly, with a mental image of how they would look like when they grew up and what they would do, things that you'd enjoy together. And so the grieving process happens not just regarding the real baby, but regarding the imagined baby that you had. And we sort of have to oppose the hopes that we had with the reality that actually exists. Parents often form attachments, and I say often because not all parents do form attachments to their children and grieve their death, regardless of the gestational age of the pregnancy, meaning that it can be 1 week old or it can be months old. It does not make the pain easier. Of course, it depends on how attached you are to that pregnancy. And the provision of high quality and consistent bereavement care helps with the grief and transition to life after the loss, so parents know how to continue their lives and know how to be guided through what comes next. And the assessments conducted at prenatal visits may reveal an unexpected loss, and this is when people know that their pregnancy is no longer viable. This can happen when the patient reports heavy bleeding or cramping, when the patient reports cessation of fetal movement, when the fetal heartbeat cannot be heard or visualized, and these can all be signings of pending or complete miscarriages. Of course, we always talk about unexpected losses. However, for some people who suffer from recurrent miscarriages or have other health conditions, this can actually be an outcome that is expected. However, whether it's expected or unexpected, it does not mean that the loss is easier to process for the patient. So support is provided ideally on a psychological level. We need to screen for trauma. We can screen for depressive symptoms and a lot of other things that are going on after the loss, or when patients receive the news that the loss will happen. So there is an ongoing process of managing emotions. Support is also provided ideally on a social cultural level, meaning that we try to understand what the cultural backlash will be of this happening, how the person will then face the world when they get out, how they're going to work, and what's the meaning of family and parenthood now that they've gone through this. And it would also be amazing if we could provide support on a spiritual level, trying to understand what the person thinks or understands of the situation. Was this fate? Was this karma? Was this an act of God? So apart from these different areas of support, patients should have an opportunity to participate in making plans when it comes to choosing what they'll do regarding the loss and how they'll approach the situation, because this can give them a sense of control as the pregnancy and birth progress. So some recommendations for bereavement services include assessing parental desires for special end-of-life rituals. And of course, we have a multitude of religions, and they can play a role on these rituals, and even the absence of religion plays a role on these rituals. We can have people who want a formal funeral. We can have people who choose to pray and have moments of meditation, of self-reflection. We can have other rituals that we aren't expecting. We aren't, we aren't always aware of every single personal understanding of all religions that there is out there. So some flexibility to allow people to express themselves is very important. And also, allow this person to continue self-care routines within their own culture, and allowing them to have access to materials, to resources that can make that wish true is very important. Another recommendation is in ensuring support for parental caregiving behaviors and gestures. This could be talking to family members. It could also depend on the gender of the person that we are specifically talking about. Of course, there's not just men and women. We need to be aware of how these people are coping with it, what gestures they find most appropriate, and how we can best assess them. And so some demographic data sometimes is helpful to contextualize these things. And we also need to understand that these behaviors can come not just from parents, but also from other family members that want to be present and have caring gestures towards what happened. And this could be physically touching a baby if the baby was formed. And some behaviors or gestures to people who have never had contact with this reality can seem very odd or a bit macabre, but the truth is that we don't know unless we are in this situation. So some flexibility and understanding regarding what these people wish to do can go a long way. Another recommendation is providing options for parents regarding the collection and offering of mementos, and this could be pieces of clothing that they had bought for the baby or that the baby got to wear. It could be little toys. It could be taking taking photographs with the baby, because photography can be a really good momentum to have the image of the baby in that moment with the family. It could be writing something like a letter. Some people like to make molds of the baby's hand or feet. Again, it depends if the baby was fully formed, if they, got to be born, if they were stillborns, or if they died shortly after birth. If it was a miscarriage earlier that they couldn't see the physical baby, it can also be good to take a photograph, the person taking a photograph of themselves in a hospital bed, just to mark the moment that they were there and that their baby did exist. And one thing that I always like to say is that, of course, mementos are great. And it's amazing to remember that although the baby passed away, that does not mean that their existence doesn't linger anymore. They are still there in your memories, in your dreams, in your hopes. So they still exist in a way. And it's good to remind yourself that dying doesn't necessarily mean that they no longer have an impact in your life. And then in postnatal period after discharge, it's good to allow parents to have follow-up contact, whether it's, through face-to-face consultations, telephone, or digital consultations, and even support groups can help a lot. So ideally, we need to teach methods of communication. When we are talking with clinicians, if we are also a clinician, we can use a different language than the one that we have to use with patients. And it can be very difficult for the staff to deliver these news to patients that, their pregnancy is not viable or that their baby passed away. So I would advise you to look into the SPIKES protocol. I might do a video on this protocol alone later, but you can research it, and it's very helpful for clinicians to deliver bad news to patients. It's also important for the clinician to be able to provide guidance about admission and the processes that will happen to deliver the baby, what will happen postpartum, or how this miscarriage, if it's pending, how do we, go full term with it. So talking to the patient and walking them through the steps, the procedures, what it means, what they will feel can be very good so the patient can prepare themselves for what's to come. It's also good to allow family members to improve their communication as well. Sometimes they don't understand what the patient went through, so it's always good to have a mediator. So ideally for these situations, it's good to have someone accredited to do those mediations and to help the family process what happened. And it's also good to have someone who can do psychological evaluation, someone who is accredited to do so. So it's good to assess parental wishes and needs. What do they want to do now? And it's also good to screen for red flags, for example, maladaptive coping strategies and symptoms or signs of mental illness or an episode that can be very disruptive, for example, a depressive episode. And it's also good to have preliminary screening of staff's ability to cope with the situations and to handle them in order to have good staff, comfortable staff, healthy mentally staff that can provide support for patients. We cannot say that the patient's mental health is more important than the staff's, because if we don't have a staff that is healthy, we cannot provide a care that is of the best standard. And it's also good to have a family-centered developmental care approach, meaning that it's good to integrate and be aware of the family's culture and what you wish to do. Again, it's good to have a psychologist. Here in Portugal, we have something called a family psychologist that is used to working with families. So that can be very, very important to mediate all the emotions. It's good to create a debriefing plan for staff members to feel oriented through their own work with these patients. Again, it's good to have follow-up calls and visits with patients, and it's good to provide information on resources, for example, hotline numbers, or, for example, the miscarriage app. So this was our presentation for today. I hope you enjoyed it. And if you'd like to leave a comment, I would love to answer your comments. And if you'd like to keep contact, please reach out to me on my Instagram at Beatrice_Regina_fertility, or you can write me an email through beatrice@efp.clinic. Thank you so much.